We present successes, we present failures, and difficulties, and try to find answers as a group. So what we've tried to do now is to move into not just the treatment of, although it's tremendous to be treating disc herniation, spinal stenosis, but 1 out of 4 people that are 95% of the cost in both human suffering and dollars in medicine today. 1 out of 4 people that you and I see in clinical practice will absorb 95% of all the money spent in treating low back pain in the United States. The source of that, the biggest authors are Tim Carey at the University of North Carolina, volume 39, number 10, the Journal of Environmental Medicine. The huge amount of money goes to treat spinal stenosis, regardless of its etiology. And so you and I, if we can handle that, we've done a great contribution to medicine. But now we see that it's time for chiropractic to begin to set algorithms of treatment for specific pathologies. We're going to look at a couple of those cases together this weekend. The first case is done by Luigi Albrano at DC. So, Doctor, you come present your case for us. Some of these are unusual cases. But you know what? That's how we grow as a profession, is by seeing these difficult cases. Thanks, Doctor.
Thanks for having me have this opportunity to present this. Just a quick background on this case. I had been treating this gentleman for 2 or 3 years for chronic low back pain, mostly radiated just around the SI joint. We did initially start with typical conventional spinal manipulation, just side posture all the time. He couldn't tolerate it well, and so I did do laser therapy on him, and it did help with managing the pain, but it was progressively worsening. He'd have some exacerbations in the first couple of years before I did Cox Technic on him. And then it was after a couple months after certification that I started doing the Cox treatment on him. He had a flare up pretty bad. So just as the title says, patient with dural aphasia, 40-year-old male, chronic low back pain. It wasn't until we had an MRI or a CT scan done that we discovered the dural aphasia. And I did request that he get genetic testing or for Marfan syndrome, Ehlers-Danlos, that sort of thing, but his family doctor just felt it wasn't necessary. So during the whole time though, this guy was a delivery driver for a garment company. And so he was lifting bags that he estimated to be about 30 to 40 pounds, whether it was clothing or table linen, maybe 50 to 60 times a day, hopping in and out of the truck with one full bag of clean linen and another one of dirty linen. But during the whole time of the treatment, he only missed 1 day of work. So he toughed it out, especially in that last episode. Treatment was, we started protocol 1 for the first 3 weeks, and his scores just improved greatly. We moved into protocol 2 afterwards. And then we continued to do the laser therapy only because he felt he still needed it, even though he had gone several weeks different times without doing any laser therapy. But I think it was more of a comfort for him to continue with that therapy. Conclusion, I really do feel that that Cox Technic was successful in helping manage his condition. It was, in my opinion, more appropriate than any other treatment out there, because once you see the effect it has on the bone. So dural aphasia is defined as a ballooning of the dural lining. In his case, it was from L3 all the way down into the lower S3. His first visit, his first treatment with Cox Technic, he had great response to. Then on his 9th visit, he did have an exacerbation while working, and but we got pretty good results within, let's say, 12 treatments over 6 weeks.
If one didn't know anybody, you think that's a huge, large disc extrusion. But remember that you mentioned about the urinary. How did the leg pain do on this patient?
Oh, gone.
Because with the size of these nerves, the number one thought comes to your mind is neurofibromatosis, right? I mean, that's the big one. And so you look at the skin, see if there are any, can they allow space, spots? If there are none, then you look around and you see those huge nerve roots. Those suckers are big. That's ectasia. This is a great case, you know. And you think about neurofibroma, no neurofibroma is that exactly symmetrical, you know. And so you mentioned about the urinary problems. Well, always they put endoplexus every day in practice. We think about S2, 3, 4 nerve roots because they form the pudendal plexus. Those pudendal plexus will innervate the uterus, fallopian tubes, the human prostate, the uterus, oviducts, and ovaries. They'll give rise to the dorsal nerve, which innervates the penis, the clitoris, responsible for the sexual response in the human. And does this person have any of those symptoms? Do you know? It'd be interesting to find out. But then the next thing is the inferior hemorrhoidal nerve, and then coming off of the pudendal plexus is the perineal nerve. Coming off of that is the pudendal nerve and the testicular nerves. The long scrotal nerve goes to the testicle and the labia. And so the sphincter urethral membranaceae is really innervated by the pudendal plexus, thus the reason for the urinary problem in this case. Great correlation, eh? Those are huge nerves. Here, the size of those. You talk about an owl sign, that's an owl sign, OWL sign. T1, T2, those are huge. Very large. There's a big example here.
Is that all nerve tissue or is that all fluid?
Yeah, this is all ectasia, dilation. I mean, you can look back here and we can even see how the cord itself coming down, it begins to dilate here and then comes out here. That's a huge ectatic nerve root. And Dr. Yoakum is going to present a case of Ehlers-Danlos syndrome. I'm sure I've seen him. I didn't even know it. My stupidity. Some of you may have too. Dr. George.
As instructors, Jim gave us kind of a mandate this year to maybe push the limits of what Cox Technique could manage or what we can handle with that. Especially in Part 3 courses, we talk a lot about facets and discs and stenosis and what we do that way. So I wanted to share something that maybe was a little, as chiropractors, we think outside the box. So this for maybe a chiropractic manager would be outside the box. I only noticed one paper in the literature about treating Ehlers-Danlos syndrome. It was using machine-assisted adjusting. Chris Coloca did it back in 2003. So it had been reported in the past, but would be the first time that this has been out or published. But what I think has been new or different about this is the facts for Ehlers-Danlos have changed over time. We used to think that it was a more rare disorder that they speak of in their own literature, and I pulled most of this off their foundation site, that it was 1 in 5,000 patients that were treated with that. They now know, or they believe, that that number is getting smaller and smaller. So let's talk a little bit about this. It's a group of inherent disorders that affect connective tissue. We most of the time think with Ehlers-Danlos that it's going to be the skin, the joints, the blood vessel walls, more severe things than what we might treat. It presents with a wide variety of symptoms, and it can be unique presentation in each case. So they have classic symptoms, but each case is different. So it may be challenging for doctors to diagnose this, and that's what it says here, is that the variety of symptoms and presentation proves challenging to the medical community and the chiropractic community, if we see that as well. And many of the patients are misdiagnosed and suffer different treatments as a result of this. How this fits for chiropractic management is the patient that came to me was a 37-year-old female. She had widespread chronic pain across her shoulders, ribs, butt, calves, all over the place. We've seen these, they look like the typical fibromyalgia. In fact, that's what she was defined with before she came to me, is her general practice family doctor. She didn't like very well, so she left and didn't go to them anymore. And she was then seeking care with an integrated medical physician. We'll talk about that in a little bit. But they had diagnosed fibromyalgia and some degenerative arthritis. She's always in this chronic fatigue state. Oftentimes goes together into these diagnosis categories: fibromyalgia, chronic fatigue syndrome. She oftentimes feels and hears cracking or popping in her joints. She'd done medication in the past without much help. As we saw in that multimodal chart, it wouldn't fit. She'd done physical therapy, she'd done massage, she's done exercise. Nothing really took care of the pain. She lived in this chronic 4 to 6 out of 10 range when it sometimes jumped up. So after phone consultation with the integrated medical doctor, she and I decided that she had Ehlers-Danlos. We both thought this, but it's an expensive item to then send over to have the genetic testing. As Dr. Luigi had said earlier, you can send out for that, but these are thousands of dollars to just have these genetic testings done. So after she had this bad flare-up, we talked again and said, let's refer you over to Northeast Indiana Genetics to confirm this type. And so they did find that. Is that there are no, they rule out all the other ones based on a collagen test, but type 3 is based on inclusion by symptomatology. So they did confirm the diagnosis of Ehlers-Danlos syndrome, hypermobility type 3. She's still under care with us. She's a congruent patient. And so going back to what we speak earlier, she understands that there's no cure to her condition, but she understands that there's control over her symptoms. So in conclusion with all this author was unknown, but I like the comment here, is you can't connect the tissue, think connective tissue. So think of a disorder, we can't fill all the boxes and check this out to anything else. Fibromyalgia, chronic fatigue, some of these other ones. Think the connective tissue is the origin of pain. Ehlers-Danlos may be more prevalent than currently reported. It's not maybe the 1 in 5,000 we have. Look for some of these on widespread chronic pains, because as the citing Dr. Heidi Collins said, it might be 1 to every 100 to 200 patients, which means it will see within this year. Right? Responds well to chiropractic care utilizing toxin extraction, physiological therapeutics, and proper rehabilitation. Any questions?
Yeah. So in your research, do you think that we're seeing these?
I do.
That nobody knew it?
I do. And again, because from the pathology classes we take back in chiropractic college, you have to have like that classic vascular case, translucent skin, you can see the organs underneath, you're seeing the weird earlobes, the lobeless ones, or small stent. You think that that's the way that these genetic cases are going to be. And I think as we all learn more, I think a lot of these widespread chronic pain cases could actually be some of this clinical manifestation. How do you treat this? All it is hanging a label on it. We treat these very well. So either they go through the genetic testing and say that they have this or that they don't. It's still under management. Okay? So if it's just based on exclusionary criteria, if they have these hypermobilities, so if we understand those Baden classifications, you're halfway home with that. So if they're over 5 to 9 of those, that considers joint hypermobility. So then if they have some of the others, then it's just finding the others.
Can you care to speak about the anti-inflammatory diet, how you address that with specific?
Yeah, deflame.com, probably the easiest. It's Dr. Siemens' work. At least that's who I follow onto those ones. And you can spend hours talking with the patient on them and having them fight back and forth with you, and you can send them to a website and say, here's what we need to have you understand first. He'll admit this is the best that she's done in many, many years. So with our, at least guides to get through, you know.
I just wonder if any of the rest of you ever saw Ehlers-Danlos syndrome. You have that. What did you treat it?
We did treat her, sent her into a car accident, and she just happened to have that. She back and neck pain. She did fairly well. She said it's not really sure that we just do get her through. And I think due to insurance reasons and finances, she just didn't care about because she wasn't paying the receiver wasn't there.
Congruent, they understand you're not going to cure them. I have, and for me, most of my patients are that way. I mean, if you got spondylolisthesis or degenerative disc or transitional segment, or you're never going to be normal. So I tell them, 50% relief can be a good clinical outcome. And then they accept that. Otherwise, they just complain to me about why they didn't get the other 50% relief. This diagnosis of fibromyalgia that Dr. Yoder mentioned, I think we have to be very, very careful with that. I mean, in 1992, in the Journal of Arthritis and Rheumatism, was the first time that it was described. 10 years later, that same author wrote an article and said, I'm sorry I did this, there really is no such thing as fibromyalgia. I mean, it's supposed to be such that you have 8 or more points, 11 or more tender points in the body, morning stiffness and fatigue. That's supposed to be the big, well, you know what? That just about happens to people in the world. And so this guy comes into me, this is a family friend, called a PA, a physician assistant. And she looked at the guy, he had pain up between the shoulders. I'll tell you what, pain between the shoulders is a very serious condition to me. And so this guy had pain between the shoulders, said, well, this PA told me he had fibromyalgia. That always is a red flag. So we filmed him, and this is film. What do you think about that for Well, it doesn't look too healthy, does it? There's something wrong. It's compressed. It has somewhat acacious appearance to it. And so we look at it here on the AFP, and this vertebral body sure is a lot higher than that. And this man comes in, his wife's with him, and I said, you know what? I said, I want to do an MRI. So here's the MRI. So on T1, it's hypo-intense. On T2, it's hypo-intense. That is the most common primary malignant tumor man called multiple myeloma. He died within the last few months. But he lived
7 years.
7 years from the diagnosis.
Did several different things.
That's the vertebral body. That's fibrocaceous metastatic disease, It's a primary malignant tumor. But that's a beauty, eh? That's not fibromyalgia. We just did this case. You'll like this case. See what you think of this one. With an anterior spinal tumor. Now there's a decision. Are we going to treat it or is somebody else going to treat it? You like that kind of case? I do. So, case 120. I just put this in, as you'll see. Now, when we look at tumors on the chest, we can break it down anterior, mid, and posterior mediastinum. You have a list of what they would all be. So an anterior mediastinal mass. These are the diagnoses, considerations right here. The biggest ones are substernal thyroids are the biggest. Some people say, well, geez, the thyroid's up here and this down here. Well, okay, that's where they go. That's where thyroid goiters go. The substernal hypoglossal cyst down in front of the manubrium. So hamartomas are calcified airways, 9. These are some of the things that we consider. Lymphomas are certainly big. So what you think of this case? I brought an MD in on this one because I sleep better at night, too. Better than time. Well, right away, I said to my son Jim, he got excited. I said, well, forget it, it's calcified. Well, you want to be careful saying that. Be real careful about that. That's only if it's not your tumor. Right. So, here we take the lateral cervical. Here's this mass here. First of all, are you taught that cervical lordosis is normal? Taught that normal? I guarantee you, and you do this next week, you take the next 10 x-rays you take of the neck, and I guarantee, statistically, my guarantee doesn't mean anything, but anyway, 90% of them will be flat or kyphotic. They will not be lordotic. And when they're totally well, they will be the same. Why is that? Well, it's this reason. If you took all cervical vertebrae, wedge shaped, they're narrower at the anterior, less height than the posterior. So if you took all the discs out, the sagittal curve is going to be kyphotic. So what makes a lordotic cervical curve? The fact that the disc is thicker anterior than it is posterior. So once discs degenerate, even one of them, you're going to lose lordosis. And the more you lose, the more kyphosis we inherit. And I've got papers in my notes. I won't get to show you all those unless we can stay overnight. But there are papers showing that there is no difference in lordosis between painful and non-painful necks. Now, I know that may argue with some of your misbeliefs, but I'm afraid that you're going to lose. Like you have. You were probably taught that in school, weren't you? You can forget that. Well, anyway, there's the mass. And here it is, up here in the upper sternum. And here it is, right next to trachea here. It's calcified. So when I see this, I say, well, let's look at the chest. And so here's another view. It's a CT. You see the big mass here. And here it is. That, incidentally, is a hilar lymph node. It's like a potato node. And when I see that, the first thought that jumps into your mind is going to be, and there's a little bit of calcification right here. That's a huge lymph node. And you think about the golden lesion. Did you ever study the golden lesion in school? You did study. If you're like me, you might have forgotten. A calcified peripheral lymph node and an enlarged lymph node here are quite characteristic of tuberculosis. Remember that? Any of you remember that? Well, this isn't TB. That is a big, large lymph node. So the radiologist that read this, like they usually do, you know, what do you think he said? Let's follow it and re-x-ray in 6 months. Isn't that the answer you get so often? You know? And the big diagnosis is, the one that came up, enlarged lymph nodes, sarcoidosis. So why aren't we too excited about sarcoidosis? Because it's a granulomatous disease that is what? Self-limiting. It heals itself. Okay. Maybe that is sarcoidosis in this patient. But the patient is asymptomatic, you know, the neck and arm pain is gone. And yet, these are the kind of things you get into. I always draw somebody else in. Post-surgery continued pain patient. This one is presently treated